L-carnitine is sold like a fat torch, but its real job is quieter. It helps shuttle long-chain fatty acids into mitochondria so cells can oxidize them for energy. Having a transport helper is not the same as guaranteeing weight loss. If the shuttle already has enough cars, adding more cars does not automatically empty the parking garage of body fat. The marketing story skips that step every time. Today, we separate shuttle biology from marketing and rare clinical need from routine fat burn bottles.
Okay, but that is exactly why people click the videos. If carnitine is required to burn fat inside the cell, why would taking more not make fat loss faster? Is the bottleneck usually carnitine or something else like total calories, training load, insulin state, and whether fat even needs to enter mitochondria that day?
Picture the inner mitochondrial membrane as a checkpoint. Long-chain fatty acids are activated in the cytosol, handed to carnitine, moved across as acetyl-carnitines, then rebuilt inside for beta-oxidation. Enzymes in the carnitine palmitoyl transferase family sit at that gate and help set the pace of entry. When researchers watch fuel use, they often track acetyl-carnitine shifts as a signature of fatty acid traffic. That is useful physiology. It is not, by itself, proof that a capsule melted body fat over the weekend.
Before we jump to bottles, where does the everyday pool come from? Is a normal mixed diet already covering the shuttle for most people, or is food a weak source compared with capsules?
Right? Red meat, some fish, and dairy carry preformed carnitine, while liver and kidney can build it when lysine, methionine, and cofactors are available. Capsules become more interesting when intake is low, stores are low, or medical losses outrun replacement. Skipping steak for a week is not the same physiology as dialysis clearing carnitine session after session. Dialysis is the clearest everyday secondary lane. Patients can lose carnitine through the filter, make less in damaged kidneys, and eat fewer carnitine-rich foods. In that setting, clinicians have studied L-carnitine for problems linked to depletion, including anemia that responds poorly to erythropoiesis-stimulating agents. That is medical replacement logic, not Beachbody recomposition logic, and the route is often supervised intravenous dosing rather than a flavored sports drink.
How strong is that anemia signal in numbers? If someone is already on an ESA and still struggling, does L-carnitine actually move a clinical marker like erythropoietin resistance? Or is it mostly storytelling about red cell membranes?
In children on dialysis, a systematic review found partial benefits in some reports. Higher hemoglobin, lower ESA dose, lower apolipoprotein B, and signals of better cardiac function. The same review stressed that the evidence base is small, mixed in design quality, and not ready for casual extrapolation. Keep it in the kidney failure toolbox conversation, not in a general pediatric wellness stack or an adult fat burn stack. Outside dialysis, the loudest consumer claim is fat loss. A 2026 network meta-analysis found L-carnitine the most consistent nutraceutical among the agents compared for body weight, BMI, waist, fasting glucose, HOMA-IR, and lipids, with dose response where suggesting benefit can appear at relatively lower supplemental intakes than some hype stacks imply. That ranking is relative to other pills, not to sleep, protein, and a calorie plan. Consistency still is not a dramatic torch, and it does not replace an energy deficit. Claim discipline matters elsewhere too. One osteoporosis review in older men mentioned L-carnitine among non-drug strategies tied to bone density benefits, yet called the evidence limited and methodologically constrained. Density chatter is not fracture-proof. Acetyl-carnitine shifts after exercise can mark fatty acid traffic without proving a supplement remodeled your physique. Soft signals should stay soft.
If someone is not on dialysis and not diagnosed with a carnitine disorder, how should they judge whether L-carnitine is helping at all? Waistline photos, scale trend under a stable diet, clinician labs, or just stopping when nothing measurable moves after a fair trial window?
Safety should stay proportional to dose and context. Oral products commonly bring nausea, stomach cramps, diarrhea, or a fishy body odor at higher intakes. People with seizure disorders need clinician oversight because carnitine products carry seizure risk concerns in vulnerable patients. A steak dinner, a standard oral capsule, and intravenous dialysis dosing are three different exposure lanes, and they should not share one blunt internet warning or one blunt internet free pass.
What about medications, pregnancy, or surgery planning? Supplements get treated like snacks online, but should L-carnitine be cleared the same way people clear other bioactive products before a procedure or while starting a new prescription?
There's also an unfinished cardiovascular metabolite story. Gut microbes can convert some carnitine into intermediates linked with TMAO pathways, and researchers still debate what that means for long-term heart risk at supplement doses. Metabolomic work in other disease states already shows carnitine-related compounds can move in complex, inconsistent directions depending on diet and treatment. That uncertainty is not a panic button for every steak. It is a reason not to megadose for vague fat loss hopes when diet and training already do the heavy lifting.
If someone and their clinician do land on a trial, which form actually matters? Plain L-carnitine, tartrate salts in sports tubs, acetyl-L-carnitine, or the intravenous dialysis doses from the anemia pilot.
So the clean decision is narrow and honest. Use L-carnitine when a clinician is treating deficiency physiology or dialysis-related problems with a monitored plan. Treat obesity metabolic findings as possible modest adjunct evidence, not a fat torch you drink before cardio. Prefer independently tested labels, food-first habits, and a stop rule if nothing measurable moves. If the indication is fuzzy, the best dose is usually none. Respect gastrointestinal, seizure, medication, pregnancy, procedure, and metabolite boundaries. The shuttle is real biology. The torch is optional mythology.